Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and speech therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Welcome to Brainstorms, Functional Neuro Rehab for SLPs, presented by SpeechTherapyPD.com. This podcast is designed for the adult medical speech-language pathologist. Most of our audience members work in settings such as acute care hospitals, private practice, outpatient hospital clinics, and inpatient rehabilitation hospitals. Each episode has an accompanying audio course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. The content of this course is based on the research and experience of the presenters. The listener is responsible for researching to determine if the information and skills taught are appropriate for their clients, students, or patients. SpeechTherapyPD.com does not necessarily endorse, recommend, or favor the information shared, nor any of the claims, opinions, statements, offers, or services made by the presenter. Hello and welcome, everyone. My name is Renee Garrett, and I'm your SpeechTherapyPD.com podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for 0.1 ASHA CEUs. Joining us today is Walt Fritz. Walt Fritz owns Walt Fritz PT and Pain Relief Center. He also received royalties from Compton Publishing Limited, MedBrid Massage, and Talk Tools. Walt receives an honorarium from SpeechTherapyPD.com for his participation in this podcast. He has no relevant non-financial relationships to disclose. I am a paid employee of a private consulting firm in the Commonwealth of Virginia, and as the host of Brainstorms, Functional Neuro Rehab for SLPs, and other webinars on SpeechTherapyPD.com, I receive financial compensation. I am currently the secretary for the Communication Disorders Foundation of Virginia. Now, without further ado, we welcome our guest, Walt Fritz. Walt Fritz is a licensed physical therapist with a BS in physical therapy and a BA in community mental health from SUNY Buffalo. He began practicing myofascial release, MFR, in 1992 and is the most experienced practitioner in the central and western New York region, including Rochester, Buffalo, Syracuse, and the Southern Tier. Over the past 10 years, he has advanced the MFR work he learned and taught and now calls his work manual therapy. While there are many reasons for this updated name, much of it is due to the underlying concepts used to explain its effects. Healthcare is full of unsubstantiated claims. Helping someone with the work you do is not equivalent to those results validating the claims made. Walt teaches his foundations and manual therapy seminars worldwide to physical therapists, massage therapists, speech-language pathologists, and occupational therapists. With over 30 years of experience as a physical therapist, he combines the best of traditional physical therapy interventions with state-of-the-art methods of myofascial release. Welcome, Walt. Thank you so much for being here.
Hi, Renee. You just reminded me I need to change that bio. It's been a couple of years because I actually don't call what I do and teach myofascial release anymore. It's been about 4 years. So I just wrote a note to myself to update that on my website.
Yeah, well, it does say you call it manual therapy, and that's certainly the course that I attended back in 2022, which was fantastic and very eye-opening. As a speech-language pathologist, we don't really tend to be super hands-on for the most part, except for, of course, with swallowing instrumental exams and things like that. So it was kind of took me out of my comfort zone a little bit, I'm not going to lie.
How did that feel then to go back to the clinic and start using that?
It felt pretty good because I felt like the course was so hands-on itself that it was very empowering to go back and feel like, okay, we have the tools, let's try it out. specifically for populations with gastroesophageal reflux disease was kind of where it started, because I had a couple of people with GERD, and then with voice patients too. It was very helpful. So
Yeah.
it was a little nerve-wracking at first, but once I started doing it and became a little bit more, won't say, oh, skilled is a good word, right? Skill's a good word, because the more you
Skill,
practice,
comfort. Yeah. Yeah.
yeah, be more comfortable that you get. So let's kind of dive into your background, because I found that to be very, very interesting as part of the course as well.
Okay. The one thing that I've like the last couple of years, especially, really been trying to concentrate on demystifying manual therapy. I think that it's been, well, especially maybe for speech pathologists, not having that background training in school and on the job, unless it's handed down from someone, it's daunting for some people. It is, especially in the world that I came from, with a lot of multi-tiered level training for all these different manual therapies, where it seems like, boy, I need to take all these courses before I become proficient, right? An expert. That was my background. I mean, I came out of school and really didn't know what I wanted to do. I worked in early intervention for a while, home care, developmental disabilities, was doing a lot of different things, sort of stumbling around. And somebody introduced me to myofascial release back in the early 1990s, which was purposely presented as a mystical type of intervention. Not quite advertised that way, but it really was, where it was the classic kind of luring you into the rabbit hole to become a master of myofascial release and everything that it entailed. And I tell you, they caught me hook, line, and sinker, and I went down that rabbit hole for 10 years. But I enjoyed the work. It was different than what I had learned in PT school. I kind of emerged from that rabbit hole in about 2005 and started looking around and see what else I want to do for a living. I started teaching my own work, my own classes in myofascial release, which was not that different from how I had learned it. But then, from 2005 to 2010, I started seeing I need to kind of blaze my own trail here. And I started doing that. I started changing things up considerably. And I guess it was sometime in 2012 that I was invited to teach a one-of class in Chicago at the Chicago Voice Care Center. Jan Potter Reed invited myself and Benjamin Asher, an MD from New York City, to present that one-of class to speech pathologists. You know what? It kind of gave me a new direction. It changed the direction that I had taken in physical therapy. I certainly didn't have the wherewithal to go back to become a speech pathologist. That was a little bit beyond me, but I really kind of enjoyed this whole new idea and kind of remaking myself to kind of fit that. There was a lot of wrangling after that class because, well, I thought the class was a bomb, but people seemed to like it. I thought it was a bomb in a bad way, because I really was really ill prepared to teach to speech pathologists. Basically, I'm the kind of person, if you offer me money, I'll say yes, and then later on I'll figure out how to do it. And that was the case, right? The hands-on work went really well, but when the questions came, I didn't have a way to respond honestly. And that's what I wanted to do. So over the last 10 years, it's been about creating the course that I teach now. Well, there isn't, the course has evolved considerably from back then, but just trying to make it more, number one, evidence-based, and number two, person-centered. And that's been the thing that I've really been striving toward in the past 5-6 years, is really making a shared decision-making, person-centered approach to manual therapy, without all the mystique, without all the bells and whistles, without all the dogma that often goes along with manual therapy training.
Yeah, I think that's a really great place to jump into the shared decision making, because that was probably the thing that really hooked me in the course, was talking about that, because it's something that's very important to me. So just a little background for you. My dad had a stroke when I was 25. I was not a speech language pathologist. I didn't even really know what that was. And so I came back and went to graduate school at the right old age, mature age. I don't know. I was grown up at 35. And so I had the background as a caregiver and a family member long before I became a therapist. And so I realized all of the pieces that were missing for us as a family, as far as education, being involved in the goal setting. And so that was the thing that really got me engaged and really tuning into the things that you were saying in the course, was the shared decision making model, because I think that is so key for really all of us in all disciplines, because if you don't have that, you're really missing a huge chunk of the service that you should be providing. So let's talk about that, is just how, it's more, I think, forward in healthcare now, and it's definitely something that's being talked about a little bit more. So how do you feel like that sort of came to be not only part of what you did in the manual therapy, but just how that sort of is a model for shared decision making?
Yeah, I guess I kind of started using cruder versions of it before I really even understood or knew of the phrase. One of the problems with my background was having taken a lot of different lines of manual therapy training. It's like every single course you went to, they were teaching a different narrative. They were teaching a certain tissue is key, a certain way to touch a person is vital, or else you won't make change. And you're in a class, the doors are closed, and you're kind of trapped in this model where the educator is telling you all these facts, and you buy it really because, air quote again, the work works. But as I started to sort of step away from all that and look at all these different models, it's like they're all doing things that work and that are helpful, and maybe even from an outcome-based, evidence-based perspective. But out of their mouth come all these different words. So what I did was just say, well, what's the common denominator here? The common denominator I saw pretty quickly was the relationship that we were building, that therapeutic relationship that was very poorly talked about in all these courses, and even in my undergraduate work decades ago now. And it was just that sort of steamrolled and evolved into seeing a person-centered approach, and then seeing it really as shared decision making. And I think, to me, shared decision making embodies the original ideals of the evidence-based model, really, because we've got the research, we've got the evidence. That's 1/3 of it, at least based on that Venn diagram, or what do you want to call that, right? The evidence, you've got the clinician's experience applying the evidence, but then you have that poor lost soul down here, the patient's preferences and values. And I really started to take a look at how is it that I, as a physical therapist, whether I'm using exercise or manual therapy, how was I bringing patient preferences and values to elevate it enough to give it 1/3 weighting in my interventions? And that's what really got me going on shared decision making, because in my relationship with a patient, my goal, I'm going to step back from the word goal. One of the things I try to do is get us to be equal partners. Shared decision making, to me, embodies those basic principles of the evidence-based model. When you probably took the class a couple of years ago, I was talking a lot about how I really strive hard to get them on board with me, to be that active participant, an equal stakeholder. And then Southern California Voice Foundation invited me to do a talk last month. One of the people on the board there had been a part of a paper on, oh my goodness, I can't believe I forgot the name. Anyway, it's a theory, self-determination theory. There we go. Self-determination theory was said to be very similar to what I was teaching here. And then I read the paper and said, but there's one big part of that that says the patient has the right to say, well, you make the choices. And I really hadn't thought about it that way. I was struggling to get my patient to participate, to share, to make decisions with me. And I still do. But now I realize maybe that is truly in that patient's own wishes and best interest to say, well, I want you to do this for me. I just read that paper 2 weeks ago, and it's really it set me back a bit. I really have to rethink what I'm teaching and what I'm preaching, right? And what I'm doing in here in my office with patients.
Well, and I wonder how much of that is generational too, because I think, having been in outpatient and then in acute care for a long time, a lot of the time what will happen is the patients are reliant on us and our expertise. And again, I see it more in our geriatric patients. They're used to the doctor saying, you need to do this and you need to take this medication. We need to up your dosage for this. And so when I come in and I'm like, what would you like to see happen? And they're like, I don't know, you're the
Yeah, yeah,
expert. And then
yeah.
you have people who definitely want to be more involved, especially when it comes to swallowing. If it's someone who the recommendation's been made for NPO, but they want to maintain their quality of life. So it kind of runs the gamut, I think, depending on the disorder, the age. Definitely some people, cognition is also a factor. That's an interesting way of looking at it, because I think it could go either way.
Yeah. And I've learned to rely a lot more on nonverbal feedback. I use a couple of sort of key phrases when people sort of throw it in my lap. It's like, well, you're the expert. Do what you think is best. And, I use phrases like, yeah, I am the expert in this work that I do, but you're the expert in your life. And that's why I want you to contribute as much as possible. And I've got sort of all these things that I'll reach for when somebody is struggling to understand. There are some times when they just simply say, and I think they mean, I'd like you to do what you think is best. And like I said, Renee, this is a brand new one for me because it's been all about sort of a dog with a bone, getting them to contribute. And maybe I'm pushing too hard and need to not stop seeking it, but stop pushing so hard. I still think it's crucial. And that's the core of my approach. And that's what new learners with me, when they're learning, they're thinking, oh my gosh, I don't know how to palpate. And it's like the palpation is not as hard as you think, because you're not looking for that secret one and only problem within their body. You're looking for a doorbell that rings something up here in the patient's brain to say, now you've made a connection to my issue. And once we get past that, once we get past the thought that they have to be this like savant of a palpator, it truly gets a lot easier.
Yeah, and that kind of goes back to, speaking of the comfort level, I think the comfort level of the patients that I saw after I did the course for them providing feedback, it really was dependent on who they were, what the diagnosis was, and how old they were. Because I had some patients who were like, I don't know what you want me to say. And I'm like, I don't want you to want to say anything. There is no right answer. It's however you feel. That was, again, I think for some people, it puts a lot of pressure on them. And then other people are like, yeah, this feels weird, or I don't feel anything. Not feeling anything is an answer too.
Yeah. And then you get the whole other piece of that. I really like that feeling. That feels really good. Right. Mm-hmm. I love that question. What do you feel? Or what are you feeling? Right. Not, do you feel my pressure? Do you feel my hands? But what do you feel? Because what it does is it opens that door to not just, well, I feel your pressure, or I feel a little bit of pain, or whatever that might be, but it opens that door where they can truly respond in whatever they're feeling at that time. And I know my boundaries. I'm a physical therapist, not a psychotherapist, right? But so many times when we start a therapeutic engagement in a safe, affective way, right, the person often feels cared for. And sometimes what they say when you say, what are you feeling, really surprises you. They'll say, I feel scared, right? I feel hopeful, all sorts of things. And that's why mine is it's a very simple approach versus you need to know your anatomy. You need to go from origin and insertion to a muscle. It's like, yeah, that's some of that. It matters. It does matter. But we're touching a human being and not the digastric muscle, right? We're touching somebody's nervous system and not selectively impacting an individual muscle. If we can sort of clear that clutter out of our brains, which is really hard, especially I've noticed with speech pathologists who are very clinically driven with all the jargon. And when I start talking with my phrases, which I won't get into too much here right now, but we start talking about frozen chicken and things like that, we're like, what are you talking about? We're supposed to be experts in clinically relevant phrasing and all this, right? It's a guess. I'm just enjoying life right now, being an educator in this field, getting to work with speech pathologists. A lot of fun.
Yeah, again, it definitely brought a different perspective to my practice. And one of the things that it kind of inspired was learning more about trauma-informed care, because that sort of goes along with the knowledge of shared decision-making. In that, one of the things when I started doing some research for another course on it was that, at least in Virginia, there are no specific training requirements and no specific CEU requirements for therapists who are very hands-on in their work, such as physical therapists, chiropractors, massage therapists, skin estheticians. Even people who work in our state mental hospital do not have a trauma-informed care annual requirement. And I found that to be so interesting, because all those people are all up in your business and all up in your face and your body parts. And it was astounding to me to realize and find that out. So I think the way that you teach the course and some of the things that you bring up wasn't specifically about trauma-informed care, but it definitely lends itself towards that, and how the manual therapy part, how you need to be mindful of what the person is experiencing, because this could bring up something different than what you're expecting.
Yeah. Yeah. I just rewrote a blog post that I wrote a long time ago about shielded work. It resonates a lot with me because I look back on my past with myofascial release, and the training was one where you had to work on skin. You have to be on somebody's skin or you're not doing the work properly. And I remember that at the time. And there were basically, if you wanted to learn the work, you had to work on skin. And to a lot of people, it makes sense. But then when you go out into the clinic, working with an individual who's coming in to see you for the first time, we have no idea. We have no glimpse into their past except what they choose to tell us or write down. And I realized that, I was asking, sometimes expecting my patient to allow me to put my hand directly on their skin in areas of their body that they might feel very, very compromised. And, I wrote that blog post out of reflection on those days when I used to, for instance, when we were doing some sternal work, and I teach that now for lower laryngeal work, putting your hand on the upper and mid sternum. For decades, I would say, is it okay if I put my hand on the skin of your sternum? And they'd go, yeah. And I'm wondering, really looking back, did they really even know what their sternum was, right? But, I'd stick my hand down their shirt, basically like this, male or female. I want to think that I got permission, but I still never really know what was going on in their brain when I had my hand right here, male or female, right? And then I stopped doing that. It was a student in a class that basically showed me not that it can be done over clothing, but what that student in a class showed me was that what she felt when I had her put her hands here and I put my hand over her hands and initiated the technique, she told me exactly what hundreds, thousands of patients said to me in the previous 25 years when I had my hand directly on her skin. That was a new door that opened for me. The realization that that expectation was mine. It wasn't part of the work. It was part of what I expected. And that's just more of, to me, allowing the patient a greater role in this. And whether it's trauma, using shared decision, in my opinion, is one really good way to kind of work through that trauma-based therapy or, the background that they have.
Mm-hmm. Yeah, for sure. And I think it definitely also helps you build trust and rapport. And for me, as a speech language pathologist, I think that's one of the things that a lot of the physical therapists and even occupational therapists that I've worked with in the past, particularly when I was in inpatient rehab, and we really did have a team approach, but those two disciplines tended to be in the gym with multiple people, with multiple patients, whereas I had my own treatment room where, the patient was there alone with me or with a family member and me. And so there was an opportunity to build more trust and a little bit more. Really, it's intimacy, right? It's intimacy in that you have this rapport where they feel like they're safe and trusting and can come in and tell you things that they may not be telling the physical therapist or the occupational therapist because they don't feel safe. And not safe in the sense that what you're doing isn't safe, but safe in the environment. That part is really huge because there were so many times where they would come in and say, I had a really hard session in PT. I don't think I'm going to get better, and burst into tears. And I'd go to the PT and be like, hey, they had a really hard time today. I just want to let you know. And they're like, why didn't they say anything? Because they didn't feel like they could. It wasn't the right space and time for them. So I was going to say, I think that was another really strong connection that I felt to the course and the things that you were teaching and the way that you presented it.
Yeah. One of the things that a lot of people come into the class with, and I actually say this at the beginning of every class, that while you think you're coming here to learn some nifty hands-on stuff, what I really hope you leave here is the concept of shared decision-making. And that's truly what I want, not just in this manual therapy work, but in even exercise-based work, even other kind of works. The thought that manual therapy is somehow so different from other therapies because we're affecting the problem here in the tissue. But the more I've learned, read the evidence, not just from in the physical therapy field or, the SLP field, but going out into the behavioral health field, understanding the effective nature of touch, the way touch, it's basically an instant channel to the patient's brain. So we think we're doing this right here, but they're also participating, they're observing, they're witnessing. And if we invite them in, they're participating. And that touch has the ability to convey so much more than just fixing these issues in the tissues.
Yeah. And I think that's a really good space to talk about just kind of how manual therapy works from a speech or for a speech language pathologist in that standpoint, and how does laryngeal manipulation kind of work into that model?
Yeah, so laryngeal manipulation certainly was the forerunner. I mean, let's face it, it started, well, people love to quote Aronson 1990 as sort of the origination, but oddly enough, Aronson wrote his first book in 1980, and he included that passage on laryngeal manipulation for voice disorders, where didn't use the phrase muscle tension dysphonia, but basically manipulating the larynx. The thought was if we aggressively, and aggressive is It's a scale. What's aggressive to one person isn't aggressive to another. When I had laryngeal manipulation done on me, it felt very aggressive. I felt disempowered. I felt like I needed to hold on to the table or the chair while somebody was cranking my larynx around, right? It didn't feel good to me. And I think that me not liking it probably limited some potential outcomes. And to me, that was a key piece of that. They weren't allowing me input at all. So that evidence is really fairly strong, first in muscle tension dysphonia, but then the translation into muscle tension dysphagia for using laryngeal manipulation is a newer concept, but it's still, it's showing up in some of the research. There's fewer papers, there's fewer full-blown studies done from the perspective that I both use and teach the work. Instead of, for instance, manipulating the larynx, where the therapeutic moment is the movement, right? That's the therapeutic moment. In the model that I teach, it's what happens when you get to end range and you stay there and you allow the patient time to process, to feel, to remember. Basically, does what they're feeling now match with their priors? Is it the reason they're here in the room with you? Over the last year or two, I've actually gone back and started doing some manipulation, but in a slower way. The combination of movement plus that stillness that I've always taught in my classes. And from an evidence-based perspective, it's really got a really good, I think, a fairly robust evidence behind it, at least when we look at outcome-based studies. What's sorely lacking is, really good papers diving into the mechanism of action. I just sent you that paper a little late for you to get through it, but that is actually my first published paper is, looking at mechanism of action in laryngeal manual therapies and the comment that it's time for an update because most laryngeal manual therapy papers are still talking about, I call it the what happens in Vegas stays in Vegas perspective. You've got too much tension here. We need to manipulate it. And somehow locally, we're changing everything. But that's not really how manual therapy acts. If we are changing something in the periphery without some up and down feedback from the brain back to the periphery, it's minimal. Most of them are very nuanced, back and forth, bottom up, top down type responses, plus contextual factors, behavioral inputs, all sorts of things that come into play. And that's where I think the evidence is really lacking in the manual therapy field in your literature, laryngeal manipulation. And that was the premise of that paper that I shared with you today. And I understand you're going to put it in the notes for people as well, right?
Yeah, for sure.
Yeah. I'm a rather wordy person, and that particular journal had a limit of 2,500 words, which is like, man, I'm just getting done with the introduction of 2,500 words. But either way, I mean, at least it kind of draws some of the ideas of maybe what's lacking. And here's a lot of different things we need to consider other than what we think we're doing to somebody's tissues. And I just have to keep reminding my students, and at times myself, I'm not working with a muscle. I'm working with a human being who happens to house that muscle, right? So pay attention to the human as much as the muscle.
Yeah, that's a really good point. And again, thinking about the patients that I was able to go back and use some of the techniques with, again, there were some patients who were like, nope, nothing, don't feel a thing, got nothing. And then there were some other people who were like, oh, wow. So we talked about, as part of that shared decision making, it being okay for you to say stop, or being, I'm not going to ask you any questions. If you're uncomfortable and you want me to stop, you say stop, and that's the end of it. If you want to share further, you can. If you don't, that's okay too, because again, that's an answer. When someone says no, they don't have to qualify it, right? They say no, and you respect that. And that's, again, when you're someone who sort of has this, I'm just thinking about like when I first came out of school and I'm thinking, okay, it's my job to tell you what you're supposed to do in therapy. It's my job to give all of my knowledge and expertise to you and tell you exactly what you need to be doing. But sometimes that no is a stronger answer than what you were hoping that they would share with you to begin with.
Yeah, I've broken it down over the last couple of years into some of the simplest questions when I'm working with somebody, right? If we're working in an area, we try and go from macro to micro into finding something that, now there's that feeling you're replicating or connecting with that swallowing disorder. And what I love asking them is questions that are so simple. Does this feel useful? it's so interesting to watch somebody when you ask them a question like that, and they actually they don't have to, but they're being asked to make those sorts of comments and, in a sense, decisions. Some people just back right away from it, and other people just embrace it and realize that they have the ability to participate in their own care, which I don't know why it's such a shock to us, but I just think it is a part of everything I do, including exercise. I want to just break in for a second that another person came to my attention last year when I was giving one of these talks, and that was Leah Halau. I don't know if you're familiar with any of Leah's writings. Leah's out of the University of Pittsburgh. She's written extensively on metatherapy in the field of speech pathology. And the way Leah describes metatherapy is a new grad comes out of school working with voice. They're using techniques that are taught to them in grad school, right? They might use lip trills. And they do the lip trill because that's one of the techniques that they were taught. And I know I'm simplifying it more than a speech pathologist would, but just let me play with this for a moment. They do it, but it doesn't seem to get the outcomes that somebody, a more experienced clinician, gets. And when you watch that more experienced clinician, they're still using the identical technique, but it's the envelope that they wrap that technique. That's what Leah calls the metatherapy. It's basically the therapy that surrounds the therapy, right? People think that manual therapy is the therapy. And I mean, at least it's the medium to have access to a person. But what really is key with this work is how we surround that therapy, right? Not just let me do this because I think it's good for you, but tell me, does this feel like it might be helpful? Are we connecting to any of that? But it only comes when the relationship has been built, when trust has been built. And I think those are the factors that Leah is talking about in her papers on metatherapy. We're building that envelope around the techniques. The techniques by themselves can be helpful, but they're so much more helpful when we have context to apply it in.
How do you spell? I mean, I don't know if you know how you spell her name.
It's Leah, Leah. That's first name. Last name is Halau, Helou.
Okay, I'm just going to put it in the chat box because I know someone will probably have a question about it.
Yep.
I'll have to look that up too because that sounds like right up my alley.
Yep, and that's her right there, Leah Halau. Yep. Great papers. She's a great person, and spent some time with me doing one of these one-on-one Zoom, just kind of comparing her principles as well as what she saw in this work that I'm teaching, which is really nice because not that shared decision making is a new thing or my invention, but it's like very few people are using these concepts of not working only from the clinician's expertise, but also trying to get the patient's expertise involved as well.
Yeah, and again, a really important component of that is the buy-in of the patient, because if we're not getting, they call it the worksheet therapist, and sometimes I think the worksheets have their role for different things, mostly for home exercise practice, because we have to give them something to do. But when you're looking at that from a practical standpoint, it's usually kind of boring, right? It's kind of boring. No one really wants to go home and do a worksheet. It feels like school. And so I'm usually very frank and honest with my patients about that. Even when it's for dysphagia exercises, a lot of people were big on circumlaryngeal massage and facial massage for things like Bell's palsy in the past and some other disorders like paralysis due to stroke or paresis due to stroke. And we've kind of moved away a lot from the oral motor traditional exercises. And I think for me, this was the manual therapy made more sense because we could see if there was a connection for those patients. And so when we're talking about evidence-based practice, I think those are some areas where, again, there's some lacking outcome research for those particular disorders. But have you seen anything on the horizon for that as far as evidence-based and fitting manual therapy into more voice and swallowing disorders that are a result of something neurological like stroke?
Absolutely. Well, let me go into Parkinson's for a second. A lovely paper, and I might have shared this with you at the class. There's a paper done in 2017 by Eteras, Eteras, where they were looking at Parkinsonian dysarthria with neurodynamic technique. And neurodynamic technique is a form of manual therapy. It's said to try and free up the nerves within their tunnels. And there was a theory that with Parkinson's disease, that sometimes the specific facial muscles may be influenced because the nerve itself was impacted. And they used some specific techniques to try and, I'll use kind of a simple phrasing, to free up the nerves within the tunnel, and found it to be a potentially effective intervention. So, you're getting some earlier kind of signs. It's basically an early kind of paper. And it was basically said to be the first paper in the SLP domain that brought neurodynamic technique into it. Stroke, I've not really come across many papers with stroke recently, but I'm seeing a fair amount with post-head neck cancer, with radiation-induced type work. I quote one very frequently by Macmillan in 2022 for trismus in terms of trying to use manual therapy to improve maximum mouth opening. And I really enjoy that study. There's some downsides of that study and a lot of manual therapy studies is when you read a study, here we are, we're supposed to be able to look at the evidence and apply that evidence. But when the evidence doesn't tell us what to do or tell us what they did, I think that's a real shame. Not that they have to spell everything out, but at least give us a framework of what you did. And Macmillan's paper was a lovely one, but they didn't give the framework. But what I really appreciate about that study is they were looking at people with very significant mouth opening issues post-radiation. What they found was that the manual therapy techniques did improve maximum mouth opening. But I really appreciate about that study is the greatest percentage came from the first intervention. And talk about a bang for the buck for both the patient, but also for the clinician to say, okay, this may have merit. Instead of saying, well, this could take weeks before you start feeling it. I'm not fond of those narratives at all because it builds hope and sometimes it just falls out from underneath you. So when you could take a study like that and use that work and say, wow, you just got a decent amount of mouth opening. The study itself went ahead and said after that, yes, you'll continue to get gains at a certain endpoint, but the greatest gains were from the first intervention. Now, I know I'm sort of dancing around your original question with CVAs, and I don't have a lot with CVAs in terms of the actual research for it. I do apologize about that.
No, I mean, what you said was great because it reminded me of the paper with the Parkinson's info, because I do believe you shared that in the course, because I'm a certified Parkinson's provider for Speak Out, who doesn't pay me. I'm not getting an endorsement or whatever. There are some principles that we can incorporate when we're using these more strict protocols as sort of this side piece, I guess is a good way of putting it, because and I think you mentioned this earlier, sometimes you almost feel like you have to bombard the patient with all these things, but sometimes it's like you have to take, and I'm thinking of this more as like my patients with brain injury and post-concussion syndrome, I have to take that step back a lot of times and say, I can't continue to bombard them with these cognitive tasks because the load gets too high when they're tired or when they're overwhelmed or when they've had a full day of therapy. And I think that's the same for our dysphagia patients and our voice patients, because if you go too far, too fast, then you don't necessarily see the benefit because I think you scare them away.
Yeah. Another thing that I've really been beating a drum really loudly for is the inclusion of shared decision making in exercise. And I know in the physical therapy field, it's like you just don't see it. I was listening to a podcast a couple of years ago by two PTs that I really respect for their evidence-based outlook, and they were talking about shared decision making, and they started joking and saying, it's not like we can ask our patients what we think they should do. And it's like, okay, that's a little extreme, but take the concept of an exercise, and whether it's for a certain outcome in terms of strength or function, right? But to take the exercise like that's on the sheet that they used to pull out and customize it to make it have meaning to them. And I use this example in my classes when I had my rotator cuff repaired back about 8 years ago now. I had to go to PT, and I thought that was the lamest thing because my 13-year-old physical therapist, he did a decent job, right? But there was a sense that he was sort of mailing it in terms of the exercise. Here, they put the rubber band, that elastic band on the doorknob and said, okay, do these exercises. And it's like, okay, I know this is the drill. I'm supposed to do that. But so he walked away and I'm thinking, I'm not feeling anything except that I'm pulling on a rubber band. Nothing is resonating with me in terms of my issue, my surgery, my recovery. So I was a horrible patient because as soon as he'd turn around, I would sort of go off script and I'd start to look for things that began to have meaning for me. Now, I can't expect my patient to necessarily do that, but I think we can make our exercises, our assignments, our manual therapy, whatever it is we do. What I try and do with all of those is to make them resonate here. So they feel like, okay, I get why we're doing this, not just because you say it's good for me. When I'd find those ranges of motion with that band, I would stick with them, and it felt really useful. Of course, when he turned around and looked at me, I'd go back to doing it the way he said, right? I got better. I was a horrible patient, but it was a good experience for me to have to go through that and realize that, yeah, we have exercises which are said to be good for our patients, but that's based on these massive studies, et cetera, or sometimes it's just based on the folklore of our profession. I was reading a couple studies in the physical therapy realm that if you can customize the exercise prescription towards a patient based on things that they like to do, you're going to get better outcomes than if you assign things that they don't like to do, right? And I think we should all keep that in mind, that have the patient buy in to I call it incentivizing it, right? How can I build an incentive for, well, first of all, my patient to get better, but maybe my patient to do that homework that I think is important, and I got to build an incentive, and threats don't work. So can I let them feel it? If we're doing tongue work for, post head neck cancer, right? And I want them to do a little bit of tongue stretching. A lot of times it's sort of cardinal plane work. Pull this way, pull this way, pull this way. How about if we just do one stretch where you seek and search so you can find that place of fatigue, of pain, of weakness or something, and then hold on to that thread, not just the thread of tightness in their tongue, but that thread that transcends the tongue and goes up to their brain to say, I get it. That's that feeling I get that stops me from being able to use my tongue the way I want to. And that's where I think, and I know we had planned on talking a little bit about exercise. That's how I think that exercise, manual therapy, and all these cognitive behavioral approaches, et cetera, we can do better. We can really do better by recognizing the limits of our knowledge. They end at the knowledge of our patient. And I think that's what we could all do better with.
I love the rotator cuff reference because I tore, my dog that's now no longer with us, tore my rotator cuff many years ago, and I had to go to physical therapy because I wasn't a candidate yet for surgery. It's exactly the experience that I had, but I'm not a physical therapist, so I didn't know that what they were doing was actually exacerbating what was wrong, because I had a tiny bone spur right next to where my rotator cuff tear was. And so every time they had me going up and coming back down, I'm up and down shredding, and then having me on the bike rotating, just shredding. So I wound up I didn't have surgery, but I wound up having to go to a non-surgical ortho and get injections, and then finally found a sports medicine person who was like, oh my gosh, I'm so sorry that this happened. Let's run through these exercises and you tell me what makes it hurt worse, what you feel like is helping you. And that was the first time that I had that experience on the opposite side. So I think this was 12 years ago. So even back then, people were starting to, just depending on who they were starting to give that stakeholder space to their patients. And then thinking about, when you said tongue work, it brought up a very specific patient who I had. It was probably right around the time, or just maybe 6 months after I went to the course, who she was a retired school-based SLP. So she was already skeptical of me and my medical voodoo knowledge. But she was very lovely and very willing to do whatever, because she was having so much difficulty with not only her voice, but she had osteoarthritis, which she had 2 pretty significant neck surgeries, one ACDF, so anterior cervical discectomy and fusion, and then she had another posterior surgery to do something else that wasn't related to the cervical region. It was something with musculature in her neck. But anyway, after the 2 surgeries, she had a significant decline in her ability to manipulate food through her oral cavity, and she really felt like either it was an effective anesthesia or they had nicked something in a nerve. The nerve had to still have some connection because it still worked. It just didn't work as efficiently as it did. And because she was retired speech language pathologist, she was very attuned to the times when her voice and her articulation of her speech was off. And so one of the things that we did was the tongue stretching, which again, it took a lot of like rapport building, and she was fine. By like session 2, she was like, oh my God, please, because I felt so much better after we did this. And I'm like, how does this work? So It was an interesting connection because it really resonates with those patients that it works for. So yeah, let's jump into that manual therapy exercise and then other things that we SLPs do and how that all kind of coexists, because one of the things you touch on in the course is about how you are a physical therapist and most of us are over there like, okay, what's he going to teach me?
Well, again, in the last couple of years, the class is constantly evolving. It's constantly changing because honestly, my patients are constantly teaching me new things. And I was probably teaching a bit of this in the class that you took, where we anchor down here at the sternal notch and anchoring down, giving a fairly good tug, right? And then often I'll get the patient or the class participants, once they get a good, strong anchor downward, to swallow. And basically, a lot of people make a real sour face because it hurts or it's uncomfortable, or this makes the swallowing very difficult to do because I'm anchoring the larynx down, right? Externally, I'm grabbing the skin and all the soft tissue in the muscle, right? So if we look at that as an activity, right? If I anchor down and I ask my patient to repeatedly swallow, go through, as some people love to do, go through a set of 10 swallows, right? What we're doing is we're trying to improve the function of the swallow. But what's happening here? If the patient does have an improved swallow, is it improved because you stretched tightness, right? Because I'm anchoring, I'm stretching, and they're swallowing against resistance, creating more tension. That's a plausible narrative. But what about another narrative? What about my anchoring as creating a resistive swallow? And then the swallow is then forced to work against resistance. If they swallow better, is it because they got stronger, right? Against that swallowing against resistance. Although I argue that a lot of times when we say they need to do tongue strengthening, I think we could work on being a little bit more precise with that. Are we truly talking about strength in that let's do weightlifting to make that muscle stronger? Are we talking about strengthening, about improving awareness, improving sensory input up and motor output down, right? Because sometimes when we do an activity that's said to be strengthening, we'll sometimes see in-session gains in functional abilities or functional strength. We can't say, oh, we strengthen that muscle if we're using classic muscle physiology, but we're using basically neurocentric type explanations to explain why that person now has better function and strength. So when I talk about an overlap with the manual therapy techniques that we use, often there is this blending of stretching and strengthening at the same time, because the one thing that I try not to have anybody leave the class thinking that manual therapy is a standalone intervention. It should be embedded in everything you do, not only to say, okay, now we're going to do this other thing, but bring the other things into the manual therapy. Have them swallow, have them speak, have them turn their head, whatever it is that they're having difficulty with, get them to do it while we're doing the manual therapy holds. We do it. We did a brand new one that I know you didn't learn. We do the tongue techniques, right? We do the classic pull outward. And when I say pull, when I learned this work back in the early 90s, you grab somebody's tongue and you really pull, right? I hold the tongue. I hold the tongue with the slightest bit of tension. That it's bizarre because sometimes people are fine with you holding their tongue if they're steeling themselves for it, right? I mean, pulling the tongue. Yeah. But sometimes when you just gently hold their tongue, they'll sort of wave you off and say, that's really weird, but you weren't doing much, but that's almost too much. So I like to start at just holding the tongue. But we do the top bottom, we do side to side, we do the roll, the elevation, but we started a new one where I'll take my thumb on top of the tongue and then I'll depress it all the way down to the bottom of the oral cavity. So I'm basically pressing the tongue all the way down. We do some submental work with it in terms of the soft tissue work down at the hyoid. But then I get the patient to then, as I've got their tongue compressed down to the floor of their mouth, I'll say, okay, now lift your tongue. And they have to then create that resistance against me. And what's so fascinating, Renee, is even people with no tongue issue whatsoever, when I'm anchoring that tongue at the floor of the mouth, they can't figure out how to access that strength. Usually they pick it up like within a couple seconds, right? They'll start lifting and lifting. Finally, you'll feel some strength there. But we do that with our stroke patients where they're having weakness and I'll say, okay, lift their tongue and there's nothing there. So let's go over to the strong side, lift from the strong, go to midline and go to the other side. It also is one that really hits the doorbells of the myofunctional trained therapist, who it's all about tongue resting posture, because I'll bring my thumb up into the roof of their mouth and then I'll say, okay, now come in and you do a suction. Just hold my thumb up there and I'm going to add some resistance. And it's so cool because there's so much more sensation in your thumb than there is in, for instance, a tongue depressor. You can feel what part of the tongue isn't engaging, and you can give them a little biofeedback right there and engage that. And that strength comes a lot faster than we think it is. I've even got a couple therapists who have the IOP, and they've started using IOP as pre and post testing in terms of functional strength. And then they'll do these sorts of tongue stretch, strengthening, whatever you want to call it, in between. And I love this marriage of worlds, if you will, how you guys bring into these things. I had no idea what an IOP was until somebody told me what it was. And I thought, what a cool testing tool. Sure, you can use it for functional training, but you can also use it to figure out, did we make any change?
Yeah, I like that one a lot. And another, and I know that you've done this because you did a demo, and I think it may have been a course that you taught as well, where you actually were doing manual therapy with someone while the fees camera was going. And so I think that's a really good one because, again, a lot of times I think people hear this and they're like, oh, okay, whatever. But we do have some good solid knowledge and feedback from those strength measurements for the tongue. And now with the fees being utilized while you're doing the manual therapy. So can you talk a little bit about that?
Yeah, absolutely. We started those in 2017 or 18, and it was just sort of a random thing when the hospital I was teaching at asked if we wanted to do a demo, and I said, sure. I really had no experience, but since then I've done, I don't know, at least 15 of them. And Brooke Bielman and Kate Honer have done a number of ones that they've shared online. If your viewers are interested, I'm going to invite you to go to my website or go to YouTube and find my YouTube channel. There was a fees video that we did at a Buffalo class in 2023. And number one, it's the clearest images that I've seen on any of the videos that I've been able to have. But also it had some really unique circumstances in that video. What we've done in these videos is we take the camera, the recorded view of the fees image, and then I have somebody recording what I'm doing with the hands on a cell phone, and then I take the two videos and I match them up so they're lined up. I want to be clear that it doesn't prove anything, right, from an evidence-based perspective, but you can definitely see that as we do the lateralization or the anterior displacements, you're going to see the effect on the arytenoids, on the whole voice mechanism and the swallowing mechanism. And I personally think that there's room out there for somehow manual therapy and fees to possibly be a diagnostic tool. I'm not quite sure what it was, but it was that video that we shot in Buffalo with, and I won't go into the details because you can watch the video yourself, of what happens when I went retrolaryngeal, which is behind the SCMs, where we get our fingertips behind the thyroid cards a little bit. And what you saw in the person's video, the internal video, was how her larynx skewed. And I just think it really opens up a really neat door for us to go and experiment with these things. What is IOP? Oh, it's the IOP. Can you, I think I can spell IOPE. I think it's spelled like that. That might not be quite it, but it's basically a tool that measures tongue strength. Mm-hmm. And there's a cheaper, the IOP is about $3,000 or $4,000, which is why I'm not buying one, just to play with. I think it's called the tonguometer. Yeah, which is a lot cheaper from what I understand. I don't know. Yeah, that's one I might pick up just to see how that could do in terms of pre and post testing for things like this.
Yeah, our clinic, the clinic that I just left back in January, we had the tonguometer. And so what you do is it hooks through Bluetooth to an app on either your iPad or your phone or both, whatever you want to do. And you have the patient do tongue presses on, there's a little bulb, you can sterilize it, you put it into the patient's mouth, they press up, they press down, and then you can do other measurements of tongue pressure. So you're looking at intraoral pressure because that's important for swallowing. It's important for also voice. It gives you a measurement and it gives you a sort of a space of, are they within a normal range? Are they really at a deficit? Are you seeing more weakness on one side versus the other? Or when you're elevating the tongue versus not? And I found it helpful. I mean, it's not the only measure that you would take. It's just another tool in your arsenal that gives you more information.
And again, I'm a bit naive when it comes to all of this, and I certainly freely admit that. But I think that the combination of a lot of these different intervention styles, there's something about our human touch that can give the patient feedback that they can't get from, a tool. There's also that ability for us to feel what part of if we're talking about the tongue in this case, what part of the tongue feels like it's acting and what part isn't acting. And it's that instantaneous feedback is often fed right to the brain, and they say, oh, you mean right there? And they instantly get it. I think it's pretty interesting that if some combining more and more of these, what used to be a wall between PT and speech pathology. And I think me coming into your world and saying, here's a bunch of neat ideas for you guys to take back to your clinic. I don't want you to do everything Walt's way. I want you to use these concepts, and I want you to modify them. I want you to adapt them. I want you to make them your own or make them your patient's own instead of having to follow my protocol. And I just think that it's going to be interesting to see where this goes.
Yeah. Well, and the tongueometer also measures not only max strength, I pulled up the app just so I could look, maximum endurance, so how long you can hold it, and then the isometric endurance reps. So it's giving you some pretty good feedback on more than one thing as far as tongue strength goes. It's not just about that one hold. It's about how many can you do, how long can you sustain it, and how long can you sustain the max strength that you've got. So again, just an interesting tool.
It was funny because I guess it was late last year. I was teaching a class down in Virginia, actually. And we were doing the tongue work, and we're talking about all these different disorders that it might be appropriate for. And I always ask for people to come up from the class to be my model. One of the speech pathologists raised her hand, and she didn't tell me this until afterward. But we went through the second sequences, which is the role and then the depression. Mm-hmm. And then she said, I'm going to have to paraphrase wildly, but she's a swallowing therapist. And she said, that as I was listening and watching, and then, my previous person who was up there was all about how it affected her voice. And I'm thinking, okay, I work with swallowing all day. How is this appropriate? Then as soon as we did some of that resistance work, and she said, and again, I'm going to paraphrase, how much she felt it in the pharyngeal region and areas that were primary to her swallow, that it's not just something for voice, that you already alluded to the importance of the tongue. And I don't have to tell your listeners or your watchers that, but for her to have that internal felt sense to say, okay, I get it. Everybody can't have that one-on-one personal experience, but it's interesting once you feel it happening on yourself, and then you can translate that towards a patient.
Yeah, and actually in the course, it was funny because I had some colleagues that were in the course with me when I took it. It was in December a couple of years ago, and so Virginia has weird weather and we all have allergies here because of we're like number 4 in the country for pollen here. Go team pollen. But I was having some issues with like the weather change and being hoarse. And I had COVID about 2 months before that. And I had noticed some changes with my voice. And so that was one of the things for me that clicked, because I had a friend who's a voice specialist, and she was the one practicing on me in the course. And she did something and it replicated exactly the hoarseness I was experiencing. And she was like, "Ooh, that's so weird." And I'm like, right? Yeah. But it was a connection, and it made a lot of sense after that.
Yeah. My whole model is about finding that connection and then holding that connection. Mm-hmm. And whether it's the old model where we think holding the connection is loosening things up, or the new model, which is if I hold that connection that you just connected with, right, in terms of your past, your present, how much of the change that happens comes from you and not from me? And to me, that's the mystery of this work, and not in a sort of an esoteric sense, but I'll never know exactly why this work works. Meaning, did we affect the muscle? Did we affect the brain? Was it all placebo? And 100 other possibilities. The more I learn, the more I realize I don't really know why people change at least 100% with manual therapy. But the exact same thing applies to exercise. We think it's because they're stronger. That's just a small portion of it. I love that uncertainty, and I'm really comfortable in that place of uncertainty.
Yeah, that's when you start to learn, when you're a little uncomfortable and you seek out more
information. Yep, absolutely.
Thank you so much, Walt, for joining us. I appreciate you, and having the opportunity to learn from you again tonight was very meaningful, and we'll definitely get that link up to the article. So thank you for sharing that.
And if anybody has questions about anything we've talked about or not talked about, I'm very open to responding to emails or anything like that, whether it's through social media or my website. So don't hesitate to reach out.
Yeah, and I'll put your website in the chat box too.
Okay, great. Thank you.
I see a Q&A. Hold on. Do you have patients sign a consent?
My patients sign a consent when they come and see me, yes. It's sort of a general consent that my attorney drew up for me, that's similar to all. I don't know, you might need to modify it for hands-on, but you're touching people anyway, so I'm not quite sure it has to change that much.
Yeah, and I know for us, when you work in a health system, you typically get a general consent, like for acute care on admission. For outpatient, it's a little different. And where the extra consent comes in is when it's more of a procedure-based thing, like for a fiber optic endoscopic evaluation of swallowing. Those folks sign a specific consent form for that. So it's a little bit different, but again, great question.
Yeah, and to me, since manual therapy is sort of one of the native pieces of physical therapy, it's viewed as a regular within scope of practice. I love your Practice Act, right? Because it's so vague and ambiguous, not in a bad way, meaning if you've been trained in it and the research shows that it's helpful for diagnosis within your scope of practice, then it's usable by you. And I think that's a lovely door opener for you to go ahead and try some touch-based interventions.
Yeah. As long as you've been trained, that's the big caveat. Because a lot of people proclaim to be experts in things that they haven't really had experience or training in it. So we're trying to move away from that.
Yeah, exactly.
All right. Looks like there might be one more. What is the name of Intro
Manual Therapy course?
Oh, yeah.
Okay. My introduction is Foundations in Manual Therapy, Voice and Swallowing Disorders. And I taught in Oregon last year. The closest I am is in Washington, outside of Seattle next year. Nothing this year. But everything, all the US and international classes are on my website. I do offer online options if you're interested in that. Some people will start with the online class and then it kind of resonates with them. They'll seek out an in-person class. What's interesting to me is that I made the online classes during COVID when nobody had anything to do myself, because I'm in private practice and all my seminars got canceled. And I thought, okay, this at least might tide me over financially. And I wonder if it really is translating to the end user, whether it's you or the patients. But what was really good to hear is people really said, yeah, I took that online class and started using it immediately. And it's been really helpful. And I'm not trying to use that as a sales pitch, but I think that there are unique ways to learn this work. And COVID taught us a lot of things that can be done, right, through Zoom-based work, et cetera. So,
and this will be the last question. Is manual therapy used for tongue thrust?
Yeah. From an evidence perspective, I've never seen anything that really pertains to it. I can only say, okay, the lowest form of evidence is our own feedback. I host a Facebook group for people who've taken my class, and there's a couple thousand people on there. And I've had feedback from some SLPs that they found it helpful sometimes with patients with tongue thrust. That's as far as I'm going in terms of that. Possibly in the myofunctional community, they have an interesting rabbit hole of research that it might be worth looking down in terms of some of their resources.
Okay. Well, thank you for that.
Oh, absolutely.
Thank you again, Walt, for being here. And we look forward to seeing you again.
Great. Thanks for having me.
If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Thank you for joining us at today's podcast. Remember to go to speechtherapypd.com to learn more about earning ASHA CEUs. We appreciate your positive reviews and support and would love for you to write a quick review and subscribe.